Delegate Bell is grabbing a cup of coffee, but take your time, Delegate Bell. We have a quorum and we don't want to waste any more daylight. The first thing on the agenda is for us to discuss the tour we took early this morning, of the Virginia Treatment Center. And I know not everybody got there, but it was important for me for us to see that because that's the newest psychiatric hospital in Virginia. And to compare and contrast that with the other hospitals we visited this year in Northern Virginia and Williamsburg and Dinwiddie County and Marion and Catawba. So we can think a little bit about what our assets are and where maybe some of our deficiencies. But it was also interesting to me the advances they've made with ligatures, the things that the Joint Commission requires, and this hospital just opened in April and it's already undergoing some renovations, so it can be up to speed. Does anybody else have any observations they want to make about the visit to the hospital this morning? Delegate Watts.
Again, I thank you very much for that initiative because it was really the aspirational tour for much of what we ought to be doing, not just for minors, but for anyone who needs to have a setting that is conducive of effective therapy. I will respond publicly, as I think I shared with you directly. It would be ideal when you talk about the renovations that they already are having to go under. It's largely, as I understood it, because of the Joint Commission standards and this changing of what is a safe environment and what isn't, and all of the nuances. But even without those changes by the Joint Commission, it would be ideal if we have a protocol for housing units within any of our facilities, that kind of, I said protocol, I meant to say prototype, so that all of the, when you're in the facility, seeing a sharp edge, seeing a potential way to cut, seeing a potential possible hanging, whatever it may be, that the degree to which these can be a prototype for everything that we build or renovate, it would be cost savings.
Absolutely. Anything else from our visit this morning? If not, we're going to hear from Dr. Melton. I appreciate you being here. One of the most important things we've done the last few years was begin the process of implementing STEP Virginia, which remakes radically, I think, the format of programs at CSBs. And the whole idea is to create a system that provides a uniform care or some modicum of uniformity throughout Virginia. And I ask you to come today to just give us an update on where we stand. You know, and as I shared with you, while the legislation says that it's to be implemented by 2021, we never, and I can't speak for everybody up here, but I never really thought that it was going to be 2021, because I know it's a big lift, this whole bill, this whole STEP Virginia, and so I want some realistic idea about where we are, what we need to do to get where we want to go.
Chairman Dees and Chairman Bell, thank you, and ladies and gentlemen of SJ 47. I look forward to talking with you today. How do I get it up on the screen? Sorry. About where we are with STEP Virginia implementation. So you're very familiar with this slide. It talks about our deadlines in the code, where services that are listed are consistently available, and either they're delivered directly by the Community Service Board, they're delivered regionally, or they're delivered in collaboration with other stakeholders in the community. And so we put together this slide, which is sort of an adaptation of the other slide, to give a sense of sort of where we are in the journey, because clearly the services aren't going to just pop and be online July of 2021. And so I'm going to walk you through sort of what this slide is attempting to communicate. First of all, it's important to recognize that case management, peers, veterans, and psych rehab, they're already attempting to be developed by community service boards in their area. I mean, the recognition that these 9 steps need to be available in July 2021, plus the recognition that it's good, effective care and forms the foundation of services in a community means that many community service boards are already actively working. And so that's where the dates you can see go back as early as July 2017. But there are some other services, particularly in the area of behavioral health crisis, the third one down, and then outpatient behavioral health, that are going to take, they're a heavy lift, as you said, Senator Deeds. Some are bigger, heavier lifts than others. Same-day access, big lift because it involves a major change in the workflow of a clinic to move to a same-day access. Same thing for crisis services and outpatient. And so those will be built out over time. And you'll see in a later slide, we are asking for additional funding to be placed into the governor's budget, specific around behavioral health crisis services, and I'll touch on that in a little bit, so that we can start building that out before our next biennial budget. Because if we wait until our next biennial budget, we will only have 1 year to try and do that heavy lift, which would be difficult, if not impossible. And then lastly, the dates on the right. So you'll see, for example, the peer and family support services. We think we can have that pretty much in all CSBs by July 2019. Those types of dates are affected by 3 things that you're already aware of. The first would be ongoing funding from the General Assembly. Second would be the impact of Medicaid expansion on the payment for services of the newly insured. And then thirdly, the behavioral health redesign that we're working with DMAS on. Such that services are paid differently than they are now based off of what we want the delivery system to look like down the road. Lastly, just touching again on the behavioral health crisis services and the outpatient behavioral health, you'll see we really need to start making the lift on those now. We do have the $15 million that the agency will receive this July to start the outpatient services, so we'll be on track to begin that lift this July of 2020. But if we don't start the lift for behavioral health crisis services until fiscal year 2021, then it's not going to give us enough time.
And as I shared with you, I would hope you would be honest in your assessment of these dates. And if we need to move them out, I want to be as realistic with people as possible. I don't want to dangle out something if we can't deliver it. I want to be able to deliver it all across Virginia.
Right, Senator Dees. And we're in active discussion with the 40 community service boards across the state that, given the funding that would be needed to stand up the services, recognizing the workforce challenges that all of behavioral health and all of healthcare faces, that's going to be something we're going to be looking and watching. We believe that if the funding is there, then we will be able to stand up the services by 2021, July of 2021.
Okay.
So in terms of the steps that are currently underway, you're familiar with same-day access. Again, that's where somebody walks in the door and can be assessed that day. And then they receive an appointment based off of their level of acuity, but the goal is no later than 10 days that they would have an appointment. It's like somebody coming into an ER, they have a minor illness and they just need a follow-up, they get a follow-up in a week. If they come into the ER and they have an acute, they need to be seen, they're suicidal, then the CSB makes that priority decision. And in order to reach the 10-day goal, that's where the investment in outpatient services becomes so important, so that they have the depth and the array of services on the outpatient side in order to get the individual at the minimum an appointment, even if for a routine issue, in 10 days. Primary care screening and monitoring were underway, putting into use the dollars that came this year to stand up that service. And then lastly, for crisis services, so the General Assembly did give the agency $2 million to focus on detox services, which is a component of crisis and emergency services. The goal with detox specifically is when individuals come into the ER and they're impaired and suicidal, instead of their going to one of the state facilities or one of the private facilities, that because they're suicidal, they can be treated in a detox environment And when the substances wear off, sometimes the acute crisis becomes less acute, and then they can be managed in the community. These are some examples of the STEP Virginia definitions. I already talked about same-day access and primary care screening. So in primary care screening, in addition to each client getting blood pressure when they're seen and a weight, so typically about annually they're going to be assessed for those basic markers and then encouraged to connect with their primary care. There's also a higher risk group of individuals who, if they take antipsychotic medicines, they're particularly at risk for medical complications. And so we're going to be working with the community service board so that those individuals are identified. There is some basic lab work that's involved in screening for hyperlipidemia and obesity, and then referring those individuals and making a warm handoff for them in particular so they get care for their medical conditions. And then outpatient, I talked about, is an array of outpatient services. I've mentioned crisis services a couple times, and it's important to recognize that the crisis services that the state need to be both the entire continuum. So just like for somebody who comes in with a primary care, with an illness to primary care, they may be seen there and then they're back home. They may need to go to the ER, they may need to be in the hospital, and they may need to be in the ICU. You have to have that continuum of care for individuals who are in crisis. And so the continuum is the comprehensive array of services. So all the way from prevention, so our CIT trained officers in the field, intervening and preventing the individual from escalating in their crisis, and then routing them to mental health services, to mobile crisis, to crisis stabilization units, short-term residential. That's the continuum that we need. We also need it for all ages, for child, adolescents, and adults. And then also it needs to be for all disabilities. And so currently we have a crisis delivery system focused on individuals with intellectual and developmental disabilities, and we're building a crisis emergency response services for those with behavioral health and substance use. And we want to bring those together, one, because they share a lot of similar needs. There are differences, of course, between the two populations, but they share a lot of the similar needs, and then there are many who have more than one diagnosis. And so we'll have individuals with an ID or DD diagnosis, and they have a mental health diagnosis. And so the teams that are out there in the communities need to be trained and communicating in a way that they can care for someone with a crisis, no matter what their disability is.
Mr. Chairman, can I ask a question?
Delegate Ranson.
Most of the teams that you're training right now, who are they?
You mean where do they work?
Yeah,
Or-
when you're training individuals in the community, your CIT folks, who are they training in communities?
For CIT, typically it's working with your local law enforcement for crisis intervention training, so that when they often arrive first at a scene, and so when they come into that engagement with an individual who's having a mental health crisis, the individual does better if they interact with them differently than they do somebody who doesn't have a mental health crisis, who is just breaking the law, but otherwise their brain's working rationally. And so they would be probably the largest group of individuals who are trained in crisis intervention training. It's a basic skill set for our crisis workers as well, but it's really geared towards training individuals who don't work in mental health. How is it that we interact with individuals who are having a mental health crisis?
It's about a 40-hour-a-week program. Frankly, I think it would be good for all first responders to be able to participate in CIT.
Yeah, it's an excellent program, and Virginia's a leader in that area in terms of the percentage of our workforce, percentage of our law enforcement officers who've been trained in CIT.
Mr. Chairman,
Delegate Garrett.
I didn't want to slow down the train, but could we go back to slide 5?
Yeah.
So I'm very encouraged that we've got some definition of these steps. I think
Right.
slide 5. You've got
5?
6 up there.
One more. There we go.
So do you have a definition for each of the 9 steps? And do you have a comfort level, Dr. Melton, that that definition for each one of those is now embraced by and contractually related to each of the 40 CSBs?
So what I would say would be, we have definitions that are more detailed than the ones on the screen for all 9. And the beginning sets of metrics that we would use in communication with the community service boards on what does it mean to be performing adequately for the STEP. Those definitions and metrics have gone out once to the community service boards for their input, and now we've just received them back about a week and a half ago and have incorporated their feedback and their observation from the ground working in the community. And we're going to be getting out to them an updated version of those definitions in another week or so. And my goal would be to have a final set by the end of November, first part of December. That has been a collaborative development between the agency and the community service boards. And then it's sort of putting them into working with the community service boards to incorporate them into the performance contract over time.
Thank you. Thank you, Mr. Chairman.
Thank you.
Mr. Chairman.
Senator Howe.
Something Delegate Ransom asked about triggered something in my mind about the CIT training. And ever since we started this commission, a number of us have thought that all first responders should have that training. And I'm curious, have we got any way of tracking how many actually have had it?
I know we know the numbers we have trained, but in terms of tracking, offhand. Yeah, probably Michael. Yeah, the expert.
Okay.
Sure. We do an annual survey of all the CIT programs, and we collect how many people are trained within each professional organization. So fire, EMS, nursing, ER, nurses in the ER, police officers, sheriffs who work in the jail versus sheriffs who work on the streets. So we do have all that data.
Would you mind sharing it?
Sure.
Thanks.
Yeah, let me ask you, if I can, I visited last week with the Cardinal Academy down in Salem, and they told me that CIT training is part of their law enforcement training, their coursework now. Is that unique, or are other academies doing the same thing?
It is unique to put it in the academy, and again, we have always urged police departments to not put it in the academy. It's very hard to train a law enforcement officer how to be a young rookie cop, and some of the CIT skills are sort of contrary to policing skills. So we always encourage it to be a more seasoned officer who has a little bit more experience and who also self-identifies as, I want these skills. Sometimes it's gone through the academy and it's provided at the academy, but it's very rare that it's actually during the initial orientation to law enforcement.
Okay.
Thanks, Michael. So I talked earlier, we have the funding that has already been allocated for the first 4 steps. And as I mentioned, that in terms of the crisis services for behavioral health, if we don't receive additional funding until the next biennium, that's just going to give us a year in order to make that lift.
So Dr. Melton, you have ideas what these other things that don't have a dollar tag attached to them, do you have an idea about what they're going to cost?
So you beat me to it. So yeah,
Okay.
So what we're doing now is, of course, the original thought was that STEP Virginia, fully funded and rolled out, would cost about $151 million in general funds and about another $24 million in non-general funds. And of course, the landscape's changed. That was before Medicaid expansion. And so what we're doing now is we are looking to see, all right, what's the impact of Medicaid expansion? And then we're in the midst of putting together a needs assessment. And so our plan is to have updated numbers to you before the biennial budget, based off of how what we're seeing as the impact from Medicaid expansion, those first 6 months, and then also what the needs assessment shows us in terms of the depth of need of each of those remaining steps. I would say we would be looking to have it by this coming summer in preparation for the next biennial budget. The needs assessment should be coming in, depends on what we get back from our RFP. Maybe as early as May, we're hopeful, but maybe as late as August, depending on who puts in proposals. And we really need that to see how big are the gaps for the remaining steps for STEP Virginia.
Mr. Chairman? I would urge you to actually, not be as conservative as typically you would with these as an example, 3.7 million for primary care screening. If it costs you $100 to do a lipid screen and a cardiac profile and so forth, or whatever, that's only 37,000 Virginians you'd be screening. And that strikes me, you probably have more than 37,000 folks coming to your front door. So that number just leaps out at me that that's probably not an accurate number to the chairman's point. We just really need to have accurate and good, the best data numbers you can get us, so.
Will do. Thank you.
Thank you, Mr. Chair. Just a comment in response to that. If you see the outpatient behavioral health, 15 million, when we're negotiating the budget, obviously, you're not sure how all this is going to be rolled out as you are working with the detail of it right now. So we just kind of stuck 15 million out there, recognizing that it might be moved around for some other purpose when we get back to the next session. So
Okay.
I guess we'll make that judgment call based on you all's recommendation.
All right. Thank you. And then I just wanted to touch base on the work that's being done with Medicaid on redesigning the system so it supports the delivery system of the future. And so you can see Step Virginia is focused on the community service boards and the safety net public delivery system. Medicaid and the redesign is focused on the entire delivery system that's impacted by Medicaid, which would be the entire delivery system. And one of the key components is the integration of primary care and behavioral health. And the reason for that is when you look at the slide, about 37% of individuals who have a mental health issue present to primary care, an equal percentage present to mental health. And that's partly because individuals don't understand they have a mental health problem. They're tired, or their heart's beating fast. They think it's a heart issue, so they go to primary care when in reality they have a mental health issue, as well as just availability and access. And so many community service boards are already moving down the path of integration with primary care, whether it's like in Region 10 where the FQHC sent over primary care providers, or on the Eastern Shore where the CSB put behavioral health providers in the FQHC there. There are different ways to integrate primary care and behavioral health, but that'll be a key component of the redesign health system. Then I know you already heard a lot about our challenges with our mental health crisis, so I think the key thing there is there's a lot of activity underway to try and address it, and I can take questions specifically around that. And that's my presentation for today.
Dr. Melton, are you all going to be making recommendations about legislative recommendations about how to address this hospital crisis?
So there are still conversations between our agency and HHR and the governor's office about what is it that would make sense with the upcoming General Assembly. We don't have specifics to share at this time.
Okay. Are there any other questions of Dr. Melton? Okay, well, thank you very much.
Thank you.
Appreciate it. Okay. The next thing on the agenda is a funding request for the remainder of the year, I think from Dr. Bonney.
Thank you, Mr. Chairman. Try not to take very much time with this. I hope it's a pro forma matter. This goes back to the request that the Joint Subcommittee made back in, I think, the fall of 2017. As we were moving forward with STEP Virginia and thinking about the expansion of services, the Joint Subcommittee was very interested in the members in the structure and financing of the CSBs, matters we obviously were talking about this morning, and interested in a comparative study of other states and so on, as you all remember. We executed a contract with the Division of Legislative Services in December of 2017 to continue to investigate that and present, as you know, a number of presentations that we've made to you over that period of time. And what we need is basically a supplemental funding, which I think is already available to extend the existing contract, which was in October October 15th of this year to the end of the year. And so the request that we're making here in order to be able to cover personnel and consultants for that period is $24,300.
Okay, is it my understanding that this was covered formerly by a contract with the department?
This part was not, actually. This part we had always done separately with you.
Okay.
And so this is, there's issues relating to the contract with the department, but this is all entirely related to the study that we did for you with the, what I understood to have been an appropriation for support of this study.
Okay. Are there any questions of Dr. Bonney?
Mr. Chairman?
Delegate Garrett.
Dr. Bonney, do you have deliverables for the?
Yes, so the contract itself identified it. I think I probably didn't do due diligence myself in noting that the contract itself extended only initially until October 15th. What we promised was by the end of the year, a full report of the many investigations that we've done. There have been individual presentations that we've been making for a year to the Joint Subcommittee, but what we actually promised to do was to compile all of that in a full report, which will be due at the end of the year. So that's basically what I'm asking, and we are continuing, of course, to make additional presentations, and we'll presumably make additional ones at your December meeting as well. So the individual slide presentations as well as the written reports have been made as we've been going along, but we have a final report in mind that we obligated ourselves to do at the end of the year.
Mr. Chairman?
Delegate Garrett.
I don't know, Mr. Chairman, what relationship we have with, I guess it was Dr. Miller, used to be with the Colorado folks. I don't know if we have a financial relationship with them, or are they working through the Institute, or how does that work?
We don't have any financial obligations to the people in Colorado anymore.
Okay.
There was never a financial obligation there. We have not entered into a contract on that matter at all.
My recollection, at the time they were doing work with us, we were working through a grant, I think from Johnson & Johnson.
No, the relationship in that case was between DMAS and the center, and we were receiving information and we're looking into ways that they may be able to partner with this joint subcommittee moving forward. However, we never really came to a conclusion on that matter, and there was no formal partnership or relationship ever created.
And Mr. Chairman?
Delegate Garrett.
So we had some funding appropriated to the Joint Commission for its assistance with data and management. Have we already spent that, and this is new monies above that?
No,
or is this
we have money still. We've not spent the money that was allotted to us
Okay.
for research and for hiring consultants.
All right, thank you, sir.
And in fact, I think you'd be quite pleased with our stewardship of those funds. We haven't spent a whole lot of it. Are there other questions?
Mr. Chairman,
Senator Hanger.
When we said "we," it depends on how large the "we" is. I understand the administration or DMAS has been working with the group from Colorado, haven't they? Is that correct
They
to
have,
say?
yes.
Or
Yes, they have. That is completely separate from this joint subcommittee and any funding that we have available.
But Mr. Chair, you know, as the chairman of finance, your "we" is bigger than my "we." My "we" is this commission.
What I'm trying to get at is there, Mr. Chairman, is there coordination, or are the two operating independently of each other with perhaps not this overlapping or even contradictory direction? Is there a possibility? Anyone here? Daniel, are you aware of what the work that y'all are doing? Is that filtered through the Colorado group, Mr. Chairman?
So as I understand it, the work between DBHDS and DMAS is pursuant to a separate contract with the Farley Center that's funded by DBHDS and primarily by DMAS.
So it's a matter of coordinating. I think obviously, Dr. Bonney's group, UVA, is valuable to us, so I would move that we, honor the contract commitment, extend the money.
Well, let me just say, in advance even of that we have been in touch with the Farley Center and coordinating with them. So you'll be pleased to hear that.
Okay, there's a motion and a second. Or is there any further discussion? All in favor? Say aye. Aye. Like sign for those opposed?
I'll abstain.
Okay, one abstention. Okay.
Thank you.
Now we have our recommendations for 2018 and our 2019 work plan. Senator Hanger, mine, I mean, you're the chair of Work Group 1. My impression from that meeting is that most of the recommendations are going to wait until the December meeting, but there will be one recommendation to develop a letter to request that JLARC come up with a funding formula or funding model for the CSBs.
That is correct, Mr. Chairman. Would you want me to present that
Sure.
to the Commission? Mr. Chairman, I would move as a recommendation of Work Group 1 that we instruct or ask staff to prepare basically a letter of understanding of how we would want to proceed with a short-term study to deal with a proposed funding method for CSBs. Did I get that about where we had discussed this
I think
one?
so. It's my understanding, JLARC, this is a very short-term study, one that they can probably be done with by March under the new model of the healthcare studies.
Right.
So Senator Hanger's motion, is there a second on that? Second. Okay. Any further discussion? All in favor? Aye? Aye. Like sign for those opposed. Okay. We will have that letter drafted and circulated.
Mr. Chairman,
Senator Hanger.
as further report from Work Group 1, we've got quite a number of decision points that are outstanding that were discussed, and it has occurred to me that before we get to final recommendations, which I guess would be at our next meeting, that we try to move forward with that, we really need some coordination.
Okay.
There are, even as I've been here today, I've entertained conversations with some of our stakeholder groups that have ideas, plans, proposals. The administration, obviously, as we're hearing today, has plans, proposals. We really need to have some coordination, I suppose, before we act officially on that.
Is there maybe a way the work group can get together and meet before the December 5 meeting?
I think we could do that.
I
Certainly
mean,
need to.
That might be the best,
Right.
just for an all-day or a morning down here, just to hash through the ideas and come up with a series of recommendations. So December 5, we can have a full subcommittee meeting and
Sure.
come up with a list of recommendations.
We can do that. Obviously, the calendar will be tricky to put that together, but I
Yes, it
think
will.
it's important that we coordinate a little more adequately with the administration, some of the stakeholder groups, before we finalize our recommendations.
And I'd ask staff, does it make sense to try to do something before December 5?
Or that morning?
We can facilitate whatever it is you'd like to do to make sure we have appropriate discussion of whatever the recommendations are. We can look for a date, although that's going to be
Tough.
challenging.
Challenging.
We could schedule for the morning of our December meeting to allow the work group to meet and then do full in the afternoon if we need to do that.
Okay.
What I can do is work with Lindley and Chad to identify the available dates, send those to you, and you can let me know through our polling system what would be available, and we can work from there.
Okay,
Okay.
but because I think there are a number of things, and as I suggested to you earlier, I'd hope we could be as ambitious as possible this time.
Right. And that would be the reason. We could make some suggestions today, but they would be not in sync perhaps with some of the other directions people are going.
Understand.
Yeah.
Okay. Delegate Bell, you all have a series of pretty concrete proposals.
We do. Now, we had talked about sort of getting them together, presenting them maybe at the next meeting.
Okay.
Has, Delegate Rance and I were just looking at our calendars. Have we picked that next date? Is that?
December 4th.
I would like to say December 5th. That was my understanding.
I apologize. I said
I don't have either of those on my calendar. Have those been?
Formal notice has not yet gone out, but I believe the date is December 4th. Let me look
We're
at
looking
that.
at the afternoon again, I hope.
Make sure that's We haven't set the times, so we can look at how we want to arrange that.
Say work groups in the morning and full commission in the afternoon?
We can do that, if that works. We'll poll.
Yeah, we'll poll.
We'll look at the polling to make sure we've worked out the times.
Okay. Okay, and one of the ideas or at least one of the bills that was drafted before, that was brought out during work group number 2, but you suggested was probably more suitable was work group number 1, would be a proposal to extend this ECO period. And so Charles, I'd ask that you make sure that's available for Senator Hanger's work group when it meets.
Yes, Mr. Chairman.
Okay. Okay, and then on another topic, we've talked a number of times over the past few years about what would happen to this commission when our time is up, and our time will be up next December. So I think it's suitable to start thinking about what happens to us. I talked with the Speaker of the House at lunchtime today. I told him that there seemed to be some sentiment to create a permanent commission. He also has a desire to do something with some mental health and school issues. And we might find a way to marry those two ideas. But we're still in a conversation about that. And so that's what I've done. If anybody has any ideas,
Mr. Chairman?
Delegate Garrett.
So, Mr. Chairman, yours and Chairman Hanger's and Chairman Bell's, and I say this quite sincerely and quite honestly, under your leadership over the last 4.5, 5 years, a lot has been accomplished. And I actually am very encouraged that there's a lot more sort of clarity of purpose, to Senator Hanger's point, of sort of between the administration, the various agencies, and the General Assembly. I think we've put a lot. I just heard Dr. Melton, he's got a lot on his plate. I know Dr. Carey has a lot on his plate. I know Dr. Lee has a lot on her plate, all of which are, so I wonder whether the opportunity is in sort of, if you will, an oversight role of, as they begin to further implement these. It strikes me, it sounds like from what we heard this morning and what we're hearing this afternoon, it's at least a year or two before there'll be a realization of the work product that we've already given them. Now, I say that with some trepidation because, as Senator Howell has taught me in the past, if you're not working on it now and you wait another year or two, then it's that much farther down the road. And I think Senator Barker is as well, I see nodding. So I say that with a degree of trepidation, but I do believe that a lot of very good work has been accomplished. And I do believe there's a lot on the plate of a lot of the different elements of the agencies, and how that we have a Health and Human Resource Oversight, senators and delegates. We have JLARC. We can give them studies from time to time. I think they're very receptive to having that, whether it's from individual members of the General Assembly or from sort of collective bodies. We've talked about Joint Commission on Health Care, sort of having an expanded role. But it strikes me there's a lot on their plate now.
There's an awful lot, and I'm not interested in making work for anybody. I remember having lunch with Dr. Bonney after, I guess, the week after we got this resolution passed back in 2014 to create this work group, and he said, the work will never be finished, and the work is never finished. And even if it's just oversight, even if we're just looking at things that we haven't gotten around to in the last 4.5 years, there's still things that have to be done. And this needs to have a place where it can go, whether it's expanded Joint Healthcare Commission. I mean, I'm open to all sorts of different ideas. But I did want you to know that I'd had the conversation with Speaker Cox about creating some sort of vehicle for this to go going forward. Anybody else? Okay, is there anyone in the public who hasn't been heard or wants to be heard? I know we had public comment with both work groups.
Those are different things.
Right, they are. Okay. Okay.
Just very quickly, Jennifer Faison, Virginia Association of Community Services Boards. Just two comments. The first is that we really cannot thank this subcommittee enough for all of the time, attention, effort that it has devoted to the behavioral health issues that the people in Virginia face. And I've been connected to the legislature in some way, shape, or form way back from 1998 when I worked as an information and public relations officer in the House of Delegates through today, and I've not ever seen the kind of sustained attention to issues of such great importance. And so for that, I just wanted to make sure that you all knew how appreciative we are. In speaking to a couple of the points that you all asked the commissioner about earlier, we are in negotiations about the definitions, the remaining definitions for STEP Virginia, and we're hopeful that what we'll end up with is actually some definitions that will truly improve the behavioral health system and not a set of definitions that we're close to meeting already, if that makes sense. And we want to make sure that we are really kind of raising the bar and that the funding that would accompany that would be sufficient to do so. We're threading a needle and taking a risk, putting ourselves out there by saying we really do want to be aggressive with these definitions in the event that they're not fully funded. But we do think that that's the right direction to go. In addition, I think, in terms of the outpatient services piece, which really was that step 3 of STEP Virginia, the $15 million in 2020 is going to go a long way to beginning to build that. But I did not see in the DPP, in the agency's budget submission, any additional funding for that. And I would submit to you that we don't think that the $15 million is really fully funding that outpatient services piece. And that really is going to be the backbone support of many of the other things that come online after that. So it may be that the association puts in a separate budget request for that funding. And I think you'll note too in the decision package from the department, the request for crisis services is around $20 million, but only $10 million of that is designated towards mobile crisis, which is the actual step in STEP Virginia. The other funding is greatly needed, but I just wanted to draw your attention to that because probably that $10 million is not going to be enough to achieve the goals of the definition, whatever, unless it ends up being something that would be manageable for $10 million. Thank you.
Thank you.
Thank you, Mr. Chairman, for taking an additional comment. My only thought would be the mention of the extension of the ECO period. We'd like some more information on that. I know that.
Well, I want you to be at the table when that happens. That's why I suggested to Senator Hanger that he set aside some time so that everybody can have a place.
Well, I jumped up. Thank you.
Yes.
Hello, my name is Sharita Martin, and I'm a parent of a child that's on the spectrum. It's my first subcommittee meeting, so I'm sure I missed a whole lot. But my question is there anything being done for adults on the spectrum that has a substance abuse problem, where they can go to be treated at a facility that treats people that specifically is on the spectrum or have this is what I put down, intellectual disability? Because I am trying to find a place for my son right now, and I can't find anywhere. And that question is anything being done to, to do anything about treatment facilities for people on the spectrum? And the other thing is, until that is done, will money or can money be allocated for treatment outside of Virginia for these people to get treated?
Those are good questions. I don't know that anybody up here is going to have the answer.
Mr. Chairman?
Delegate Garrett.
Where is home, ma'am? Where do you live?
Norfolk.
Norfolk. So, Jennifer, could you do me a huge favor and get her in touch with the CSB person from Norfolk, where her catchment area is? And if you would, just have a conversation, if you've not had a conversation with that
I've
person.
had many conversations with them, in fact.
And who is your delegate and your senator, ma'am? Excuse me, Mr. Chairman.
Senator Sproul.
All right. So you're not going to find a better man with a greater heart that is well beloved by every person up here. So I would certainly get your son's information directly to Senator Spool, and I'm sure he will be happy to have a conversation with us. And if there's something specific that we're missing or we haven't already addressed in the system, then we need to know that as well. So I appreciate your advocacy for your son, ma'am, and I say that sincerely.
Okay, thank you.
Okay, is there anybody else? Okay, thank you very much.